Hello, dear friends. It's a good time to with you with a good interaction in UNMICRC Institute of Cardiology academic program. And again, we are meeting with my next topic of anesthesia for minimal invasive cardiac surgery. So this is one of the biggest hospital of the country, having a highest exposure to all variety of cases, including congenital to adult patients. And again, I am sharing a single center experiences of more than 1 decade in mix. So we had lots of very good exposure in all kinds of cardiac surgery in adult as well as pediatric. So as per the time is going on and the science is improving day by day, there is also a good innovation in cardiac surgery also. Previously, I'm briefing you something. Previously, we used to work with the big incision, then big fear also for the patients, and they are more worried regarding a cosmetic purpose and all. But nowadays, with the help of some invasive monitoring, some techniques, some technologies, the skill of the anesthetists and surgeons and all, we come to perform all kind of surgery with minimal incision through thoracotomy, through midline or various other options, so that we can serve better to the mankind and removing the fears. So I am sharing a single center experience of more than 1 decade for the minimal invasive cardiac surgery, and I am thankful to my team, my HOD, my colleagues, anesthetists, surgeons and everything, to whom we are successful for this mission. So in the I can say that it is a keyhole expertise, it's a keyhole surgery. So with the minimal exposure, you have to work maximally. It needs a skillful job for the surgeon, perfusion and anesthetists, and at the end of the work, you have big fun and you enjoy the day. So as is my routine belief that the cardiac theater is another spa for us. That routine public is having a spa in the market, but we have the spa in operation theater, that is a surgeon, perfusion and anesthetists, and this spa is giving a very good effect to the patient for the mental relaxation and the better health. So this is a scenario where which kind of surgery we are performing through this minimal invasive technique. On the right side, second intercostal space, we are doing aortic wall replacement. For the fourth or fifth intercostal space, just lateral to mid axillary line, ASD and MVR side, where we are doing routinely. On the left side upper part, second intercostal, the tautology of Fallot, and fourth and fifth intercostal space, it's a coronary arterial bypass grafting. So these are the most commonest pathology in the cardiac field, and we are performing through our new technique. This is our data of last 10 years regarding our work performance in ASD, VSD and TOF. That's we started with the 2 cases and we reached up to the 37 cases in a year with a near zero mortality. VSD also the same. Tetralogy also we perform very good in the mid era between 15 to 18s, and still we are doing it with having a very low risk and very low mortality. So this is again surgery wise the division from 2013 to 2022. We did highest number of cases. This is the total data of our hospitals. That's a CABG. We did total up to 15,000 till now. It's not a mini, but it's a total of work output with the mortality of less than 3%, 3.5%. That's we are matching good data at par at international level. ASD also we are doing total, we do more than 2,500 cases with a mortality of less than 2%. VSD also 4,000 cases and the little mortality bit high because of we are taking some high risk cases, some complex cases, and some of these that's a multiple pathology along with a VSD, and for that little bit have some complicated cases, and that is our little bit of area where we are looking more concentrating with our good setup. The tetralogy of Fallot, again it's a complex cases and we are performing with good results. MVR, AVR and double valve replacement also we are doing large number of cases. So the average output is more than 5,000 cases in a year, out of which our most of the 10% work is for the minimal invasive surgery. So the question will come, why minimal invasive? We are already achieving a good result with the midline big incision. It's a time tested technique. Then why we are switch over to another technique? Because there are some of the points where you are be very much happy to perform the surgery, but if you see from the aspect of the patient, when patient goes home in post-operative period, come for the follow-up, patient will come to you, will be happy, but what the some points which is remain in the patient's mind, that's what kind of trauma he has faced during the surgery, what kind of scar, because see, young age patient more worried for that matrimonial lives and all the cosmetic purpose, they cannot wear some amount of clothes because of the incision, so they are more worried for their social lives. They are also having a very big fear of the pain, the hospital stay, the hospital bills, and when they will come back to routine activity, and because of the scarring, everybody will ask, oh, you are the cardiac patient, where you did surgery, and what. That is a repeated trauma to the mental health of the patient, and for that, if you perform the mix, that's minimal invasive cardiac surgery, it will solve majority of the problems, like it is having a less surgical trauma, the scar is reduced, it's having a lesser pain, the hospital stay also reduced, and it will definitely affect the bill of the patients, and patient will come to early routine activity because of very fast and good recovery. The advantage is it also decreases the post-operative respiratory dysfunction, like atelectasis, some pain, some patient have breathing issue, some kind of low ventilation, or some some effusion, or some retention of secretions and all that. This all kind of problem will increases the hospital stay and some kind of respiratory infection. So you will decrease with the mix. Again, I told the pain is minimal because the size of the incision is very less. There is a decrease in chest instability and deep wound infection. That is always, most of the time happens with a big incision, and that part you will be avoid with the mix. There are very low chance of the bleeding and atrial fibrillation in coronary surgeries or something. If you go with the midline incision, big incision, routine standard technique, the case report is there. Patient, most of them having atrial fibrillation because of the handlings and because of a tissue problem, edema and all something. But even though the bleeding issue is much more, because larger cut, larger vessel will cut, and larger high chance of bleeding. But in minimal invasive, because of the size of the small incision, you will reduce all these problems. If anything is having an advantage, definitely it's having a disadvantage also. So disadvantage, like a patient safety. Why safety? Because you are doing with the small hole and you have to work in a big area. Sometimes if you are not skillful or something abnormal will come to you, definitely that may be some problem, and patient safety may hamper. So you have to be ready with the conventional technique if something goes wrong. But with the expertise, you can minimize the complication and maximize the safety. And sometimes if patient is suppose some issue, some problems, some difficulties, some anatomical abnormality, in those kind of patient, you have also prolonged intraoperative period. Of course, in all the patient is taking little longer time than routine technique, because you are used to with so many years, and now switch over to the small things, like you have to eat with the chopstick. But by the practice, you can also perform a good job in a limited period or in a short span of life. Again, minimal invasive is having a surgical exposure is minimum, because it's a small area, small incision, and you are working with your eye. So there is a limitation of the vision and limitation of the access, and because of that, you have to be need more skill, and definitely it's little bit of stressful in initial or beginning of the procedure. Sometimes you are not able to perform 100% revascularization. Sometimes you have to miss something, that may be possible. But nowadays, with the technology of transesophageal echocardiography and other things, laparoscopes and other instrument, you can do a complete job without suboptimal results. Again, it's a teamwork, and my part is as an anesthetist, what's challenges to us and what's our aim. So I'm having a classifying these things in various points. Like first is a most important is a pre-anesthetic assessment, pre-anesthetic checkup. The second part comes to the pre-medication, where we are maintaining the patient with calm and relaxed condition. The intraoperative monitoring, then vascular access, the perfusion technique, intraoperative care, and postoperative care. These are the points where we have to be focused so that we can minimize the complication and have a very good result in postoperative period. So let me discuss one by one. First is a preoperative assessment. So in the most of the time routinely what we are looking, but in these cases you have to specifically look for the peripheral vascular disease. If patient is having a angiography to the femoral root or something, you have to be more careful, because in minimal invasive surgery, when you are doing on pump, most of the time the surgeon is taking a right femoral for the cannulation in either artery or in the vein. So that part has to be spared for the surgeon. So this patient is posted for the cath. Definitely there is a good coordination between the cardiologist as well as the cardiac surgeon, that right groin should be spared for them. For the coronary, most of the setup is now doing angiography through the radial approach, so the problem won't be happen. But in definitely if you are using a femoral access, you have to be more careful. You have to take the distal runoff of the aorta if you did angiography or something, so that during the cannulation of vascular structure you may not facing any problem unnecessarily intraoperatively. You have to check for the thoracic aorta curvature, any atheroma, any plaque, any blockage or something, or any occlusion of the lumen, so that definitely you will come to know before doing the surgery. Then patient may in congestive cardiac failure, you should be looking properly to the patient, have a proper medical management, stabilize the patient and plan for the surgery. COPD patient, it's very important you have to be maintain the pulmonary function test, because sometimes you are going with a one lung ventilation in some of the surgeries like coronary artery, and a patient is having a COPD and patient is ABG is not good, PO2 is less than 65 and PCO2 is higher side. Definitely such kind of patient is giving a intraoperative trouble, and you have to be more careful, because there are various technique for the one lung ventilation that's come from previous era to now, the up to the fiber optic bronchoscope, that we'll discuss later on. The chest irradiation, suppose the patient is having a deformity in the chest, any scar or any trauma, any pigeon test, any depression in the sternum, these all are the things that can give a problem during the surgery. Obesity, again, that is more important, because it starts with the geriatric issue, and obesity also is one kind of additional risk factor, because obesity is patient having a respiratory compromise, then intubation problem, then cannulation either artery or either vein, then taking a conduit, having a incision, then all the chest diameters and all. These all are the things give intraoperative trouble. So you have to be check the patient properly before taking the patient and plan the patient for the minimal invasive surgery. The patient is having a pulmonary arterial hypertension. In all kind of cases, once you are going with the one lung ventilation, you have to be more careful with the respiratory physiology and pathology. If patient is having a previous cardiac surgery, the scar effect or something like adhesions, then there's a accidental trauma to the structure, any tear or something, that will be create a problem intraoperatively. So most of the time previous cardiac surgery, the risk factor will be higher, and you have to be more vigilant for preparing a patient. Then if patient is having a esophageal web varices, you cannot put a T. If patient is having a hiatus hernia, see all these factors you have to look before taking the patient for the surgery. If patient is having any acid reflux disease or any heparin related problem like bleedings and all, so you have to be more careful. Patient is having a cerebral vascular disease in carotid problem or something, so in those kind of patient you have to be taking a special care and be careful that you cannot damage the neurology of the patient. Some orthopedic abnormality like position of the patient you cannot give because of the issue with the cervical spine or any other limitation in a joint movement. Again, the pre-medication and preparation of the patient is must. Most of the time minimal invasive, we are selecting some group of the patient for congenital problem like middle age male or female. These all are the patient which is more anxious before the surgery, because this is a first time experience, because most of the time the patient is having a cardiac issue. They are already under the stress because they know the is one of the major disease, and they will be either successful or they won't be successful. So they are too much anxious regarding their futures and all. So adequate and proper pre-medication is very important for such kind of patients. Basic monitoring that we are doing is a cardiogram, invasive blood pressure, then central venous pressure, pulse oximetry, and end-tidal carbon dioxide. Another is the cheapest monitoring is temperature and urine output. One should never forget, because it will give so many information if you are careful in ICUs and all. The another additional precaution or additional work we are preparing for the mix is a defibrillator pad you have to attach, that we are not using in case of midline conventional technique or midline sternotomy, but of course we are using in case of redo cases. So a defibrillator pad is necessary, because in small surgery you won't have any enough space to use a paddle, and definitely you have to defibrillate the patient if patient is having a VTVF something, and defibrillator pad is helpful at that time. SCG lead application is very important, because you have to apply the pad and some positioning technical also. ECG should be applied properly. Arterial cannulation is very important, either right side, left side, or both sides, depend upon the type of surgery what you are taking. Most of the time, if you are doing a coronary arterial bypass grafting, that CABG, we are doing with the Lima with radial, or some Lima Y or something. In those kind of patient, you have to spare the radial for the surgeon. The dominant hand should be cannulated, and the non-dominant hand should be spare for the surgeon for the conduit. Sometimes most of the time, if it's a non-coronary case, we are taking our lines on the left side for the safety of the patient, and another is right side is sometimes if you take central venous cannulation, if you accidentally puncture the artery and you compress the either carotid or the supplement, the right side vessels should not be damp, or should not be if you give a pressure to the right supplement, you may not have access with the radial artery on the right side. So our criteria, first preference in non-coronary is the left side radial cannulation. Both in some of the previously cases, they are using some cardioplegia through the femur, through the aorta, where they are occluding both radial and both side radial to check the exact position of the cardioplegia cannula, and for that purpose, but we are not using in our setup. The right groin, as I already mentioned, you have to spare for the surgeon for the cannulation. The CVP cannulation of the left, or most of the time CVP cannulation either left IJV or left femoral, because sometimes some of the surgery the surgeon is taking a superior vena cava access to the right interjugular, so you have to be spare for that. If they don't, you can utilize it. Sometimes they are giving a cardioplegia through the SVC through the right internal jugular vein. The T is very much helpful if you are giving a cardioplegia through the SVC line or through the right CVP line, and for retrograde cardioplegia also. And there are so many other things that you can find out with the help of TE. The induction and maintenance, the aim is very much clear. I am not going into the detail what kind of drug we are using, that routine practice of vacuronium, midazolam, fentanyl and all. And the inhalation, we are using a sevoflurane or isoflurane. The aim of our surgery is we have to maintain the heart rate, blood pressure and systemic vascular resistance. The most important is the DLT technique. So previously the double lumen tube was not available. So it's very difficult to have isolation of the lung. Previously the double lumen tube was available. It's need a good skill, good technique and your experience to have a proper insertion of double lumen tube. But after that the bronchial blocker has come, univent tube has come, and with the help of hyperoptic bronchoscope the respiratory issue is sorted out, and life has become very easy for the anesthetists for lung ventilation. So I am summarizing some of the bronchial blockers which are available, that is the uni blockers, then and wire guided endobronchial blockers, then Cohen's endobronchial blocker, easy blockers, Viva site endobronchial blocker. These all are the various kind of blocker available in the market that as per your availability and your experience you can use in your setup. But definitely, of course, fiber optic bronchoscope is must. The pediatric, so for the guiding of this catheter blockers and all. So these are the that we are using in our hospital. Univent tube, there are the two ports. One port goes into the tracheal part, and second portion that here you are looking here, it is a just like a boogie, and you are going at the right side or left side depending upon the type of the surgery, and you can block from outside, and you can have one lung ventilation. So this is a double lumen tube. This is my technique of the boogie guided. So previously we don't have bronchoscope, so we are using a boogie to get entry access, and then accordingly the anatomy we are turning the tube either on the right and left side, and we are fixing the tube and achieving our goal. So this is the way how the double lumen tube work. One side tracheal lumen and one is a bronchial lumen. This is a patient of the right side intubation, and we are sparing a left lung. So left side is a collapse, and right side we had already blocked, and the left side we had ventilate the patient. Again, there is a very good role of the TE for such kind of surgery. The most common role of the TE, you have to confirm the diagnosis. What you will take the patient. Sometimes accidentally you may find ASD, PFO, or left SVC also. 90% of the patient ASD come with the TAPVC, or coronary sinus type ASD most of the time come with the left SVC, and this is very important to detect this unwanted problem, because from this ASD, accidental finding of ASD or VSD, you can come to know whether what kind of cannulation you are going. Either you go with the two-stage cannula or single-stage cannula. So this is very important. Once you open the RA and you are finding some ASD like, then definitely there are high chances of air embolism, and definitely we will end up with big issue. Some if you put a cardioplegia cannula, that TE guide is very good in case of difficulties. The venting after the surgery is over, that venting, then de-airing, that is mostly very good possible under the direct vision of TE, and definitely you can prevent the air embolism and neurological problems. The cannulation of ASD, VSD, CABG and AVR, there is a little bit of difference than ASD. You have to go with a two-stage cannula, VSD also two-stage cannula, CABG also very good, because CABG most of the patient they don't require such kind of big cannulation, because most of the our work in 99% is conducted in the beating heart surgery. So it is a octopus is most important, and another is a limited access. But in ASD and VSD, the femoral cannula is putting through the Schildinger technique using a guide wire, and you have to check the guide wire under TE guidance and pass the cannula for the two-stage cannula, and you have to go on the pump. In this kind it is very important. Then in AVR also, that you have to cannulate for the cardioplegia cannula and all. So in the limited access, it's very important that whatever cannulation you are performing, if you are doing under the TE guidance, you will minimize the complication. The CABG, you can check the proximal aorta during proximal grafting. If atheroma is there, you can guide the surgeon that this area is very difficult, you have to be more careful. Or if it's a fully calcified, you can go with the lima rather than lima and veins and all. So this is very decision making in some of the cases, but it's very important. And if there is a sign of dissection while doing a femoral cannulation, if you are not finding a wire in a right side of the chamber, definitely you can come to know that maybe some malposition, some dissection is there. So of course the T is very good. It's like a third eye of the anesthetist. Now post CPB, the role of T is very important. You have to check what's the correction of pathology, whether work is successfully done or not. Is there some gradient, some issue, some wall leakage, some improper work, whatever is there, you can check the gradient, you can check the leak, you can check the patient prosthetic mismatch, you can see so many other things after the surgery. Accidentally there may be some damage to the leaflets or residual VSD, residual ASD. What the thing is remain, you can check, and definitely you can guide the surgeon so that if you find something, you can definitely go for the correction and complete the job successfully. The complication is vascular tear, STD changes and arrhythmia is common because cannula is going and sometimes it may hit the SN node or something, or some irritability is there that you may find rhythm issues. The post-operative, you have to check with the vascular and cannulation site whether dorsalis pedis is coming properly or not. If it is not, that there are high chances of limb ischemia, so you have to be more careful in post-operative period for your cannulation sites, so that you can prevent the unwanted complication like hematoma or limb ischemia. The pain is mostly, compared to the conventional technique, it's minimum, so you can go with the IV painkiller like a fentanyl infusion or any NSAID as per your institute setup. The post-operative assessment is very important because once you are putting a double lumen tube and you change over from double lumen to a single tube, and there is a 2 times intubation, so multiple attempts of intubation or some big tubes and some one lung ventilations and all these, all kind of technique can give little percentage of that's airway trauma. You have to be more careful. That may be a laryngeal edema or something that may hamper the post-operative outcome. There may be high chance of aspiration if you are damaging some vocal cords and all. So you have to properly assess the airway in post-operative period. Always check for the sign of embolism in post-operative period. Intraoperative de-airing is not proper, or sometimes some cannulation issue or something that may give rise to neurological issues. So you have to check for the embolism either in the vascular compartment or in the neurology. And of course, the neurology assessment is very important for the better outcome. Thank you very much.